It is Thursday, February 18th, 2021. This is Pharmacology, MED240. And if you look on the announcements, this is week 7. I will be putting the Zoom lecture in here. Look at these mandatory on-campus schedule, because for week 8, week 9, week 10, we are on campus. So please email me if you cannot make those dates, because I need to give you either alternative assignments or something else, because we defined ourselves as hybrid for this term, and it's probably going to be the same for the next term as well. So there has to be on-campus meetings. So give me a call if you are unable to make it, and I need that call today, because next week is so if I don't get any message from you, I'll assume that you're going to be there, and because even though this doesn't have an official laboratory, again, we're defined as hybrid, so we have to have on-campus class. Now, again, I will not keep you for 4 hours. That's torture, number one. And number two, the protocol also states that we need to get you out of there, do what we need to do. And one of the things that I want to show you is how to do parenteral medications, specifically intramuscular injections, because in the world of COVID, a lot of people are going to get the vaccine. So you may be working for an office that administers the vaccine, and if you don't know how to do that, even though this class doesn't have a lab, that's a sorry state for you. So you really should get to lab and learn how to do parenteral meds, learn how to do intramuscular, subcutaneous, and intradermal injections. And we'll be doing it on simulator pads. We no longer do it on human beings. So, and we stopped that, I think 3-4 years ago, because an entire class, there was a contaminated saline bottle, and the class didn't get sick, but they got like a little rash, but that's enough to, to change our policies. So what are we doing this week? We're going to do, this is topic 7. This is week 7. So we're going to be doing psychiatric and related drugs. There are study questions. Please don't ignore your study questions. And if you see that you scored a 0, even though you did the work, you need to call me, because there's something going on with, the grade book. And so always look at your grade book, and especially if you got 0s. So what's due today? Of course, study questions, anesthetics, analgesics, and narcotics from last week, and your discussion 6. So let's jump right to it. Okay. Now, psychiatric or psychiatry. Psychiatry, they're doctors, they're MDs. And the theory behind psychiatric problems is that psychiatric problems can be treated not only through psychotherapy, when you actually have to talk to the patient and actually get to the crux of the matter of why the patient is feeling the way they do, and like, for example, depression. I can give you meds all day, but if we do not attack the source and find out through really good psychotherapy and history taking what is the actual source of your depression or mood disorder, then giving you meds would be useless. So when we start giving you meds, it's because we want to alter the brain chemistry. And you alter the brain chemistry, we already know from anatomy and physiology, you could play around with mood and depression and behavior. So clinical depression is severe. It's statistically, it's a little bit more women than men, but men have a more predisposition for severe reactions like alcoholism, drug abuse, and suicide. And the suicide rates for men are higher. Women would more likely attempt suicide. Men will more likely be successful at suicide. So yay, men, for, I don't know, for being more suicidal, I guess. And depression usually occurs after a stressor, usually later in life when you're in your later 20s, when you're going through stuff like graduate school. And you guys know, when you get older, you start when you're more into adulthood in your late 20s, you start realizing the party's over. There's some serious stuff that I have to go tend to. Good morning, Miss April. I saw your message. So there's different also other mood disorders. You could have mania. Now, if mania is like extreme happiness, and maybe you've heard of bipolar disorder, bi meaning two, polar, the two opposites poles. So that also commonly known as a manic depressive, right? So they have like a month of mania where they go nuts. They have now mania is like here's an example. You go nuts and you like spend all your money, you gamble a lot, and you do all happy things, including sex. I had a patient who was not homosexual and even had homosexual sex because the mania, their happiness and the drive was so intense that they were doing things that they normally wouldn't do. Now, bipolar patient, there's going to have ups and downs, and there'll be extreme ups and downs. It'll range from mania to clinical depression. And clinical depression is not only just being sad, because all of us get sad, all of us depressed, but it's when, you start having physical symptoms where you either sleep too much or don't sleep at all. It's very extreme. You either eat too much or don't eat at all. So these are behaviors that are not good for our health, and then we have to watch out for. And of course, unipolar depression, which is clinical depression, also known as major depressive disorder. PTSD, which is really common nowadays. Everyone says they have post-traumatic stress disorder. And remember, all of these have signs and symptoms that match up the DSM-4, DSM-5 now, criteria. So there has to be criteria. And you could also have things like seasonal affective disorder. That's when, when the weather gets like, winter and there's less sun, and people don't get to go out as much. So you get you get like a mild form of depression, and sometimes it even to a moderate level of depression. So the common symptoms, they're broad spectrum. You either have, it's either too much or too little, but usually it's on the side of too little. You can have lost in interest. Now, real depression, there are times where I don't want to do squat, right? And that's not depression. But when you have things like anhedonia is when things that would give you pleasure in the past no longer give you pleasure. For example, of anhedonia, you don't find sex pleasurable anymore. Just like workouts, there's a saying that, there's no such thing as bad sex. There's no such thing as a bad workout. There's always something that you can garner from it. But when you have a loss of interest in something like that, and you're relatively young, that's a problem. Every once in a while, we all have low self-esteem, but typically a normal person, when they look at themselves in the mirror, they're like, I don't look so hot and I gained some weight, but I look pretty good for me. We all have our own egos, and there has to be, a little bit of feeling that that you're worth something, that the day isn't so bad, right? Recurrent thoughts of death and suicide attempts, that's definitely in the realm of clinical depression. If your mood is so low that you're thinking about, there's no other option other than killing yourself, then these are some common forms of depression. And remember, when you're looking at your patient, you look at your patient holistically, okay? Because all of us go through all of this all the time. But if you can't snap back and this stays prolonged and chronic, then that's something to think about historically for a potential candidate for major depressive disorder, and they should go see a psychiatrist. Now, remember I mentioned psychotherapy. You got to talk to somebody. And until a couple of years ago, I used to be one of those typical people who are like, man, I'm a medical professional. I just suck it up, especially in the military. there's still a stigma of speaking to a psychiatrist or a psychologist. But I'm telling you, I wish I had more time for therapy. Well, actually, I do have more time. I really should schedule a Zoom session, because it's one thing to talk to your family members or to a friend, but it's another thing to talk to a medical professional or a psychologist who's also they don't deal with medicines, but they're professionals in the healthcare field that can really get to the crux of your problems. I'm not on any psychiatric meds, but I'm telling you, therapy, when you leave a good session, it feels like taking meds. It feels like a weight is off your shoulder, and it's really, really great stuff. But talking to friends and family, I don't know, to be honest with you, my mother's a psychiatrist. Talking to her depresses the crap out of me, right? Because we have a relationship as mother and son, so that affects any clinical care. But I'm talking to if I talk to a therapist, they're treating me as a client. They're treating me not as a family member. They can be a little bit removed. So that's psychotherapy. And me professionally, I believe you need both. You need meds, and the patient needs to talk, needs to get things off your chest. Another really cool thing, especially for people with PTSD, is group therapy. A lot of my veteran buddies, they meet every week, and just to talk it out, just to play cards or talk it out. And we go to our local VFW hall here in Maryland. I belong to several groups and we got a lot of undiagnosed and diagnosed PTSD. That's why if you guys ever talk to me around Memorial Day, I usually take a day off, because it's one of the most depressing days of the year for military personnel, because Memorial, you remember. And in the United States Marine Corps and the Naval Service, there's this thing that we do where we read off the names of lost friends, and that's hard because it brings back a lot of things. So remember, when we were kids, sticks and stones may break our bones, but words never hurt us. That's a load. Words are the most damning and the most dangerous things, and it gets into our psyche, it gets into our brain to the point where we might need some meds. But definitely meds with psychotherapy. I don't prescribe just taking meds. It's not enough. You got to get to the root of the matter, and that's what the Department of Psychiatry tries to promote. Same thing with psychology, but remember, psychology, they can't prescribe meds, okay? Now, how does depression and mania and PTSD and all of that work? Well, we already know from anatomy and physiology that a lot of our behaviors and our reaction to behaviors, right, deal with neurotransmitters. We already talked about dopamine and epinephrine, also known as adrenaline, right? And we talked about serotonin and sleep, norepinephrine with, illicit drugs. Norepinephrine, that's a happy neurotransmitter, right? Serotonin, that's happy because sleep as an adult. Remember when we were kids? Who the heck is stomping upstairs? It's probably my son. Belle, can you go tell him to stop jumping around? It's starting to piss me off. Okay. Again, ruining my neurotransmitter mood. So neurotransmitters, it's your brain chemistry. It is the chemical produced by the nerves because remember, our nervous system signals are not only electrical in the form of the action potential, they're also chemical neurotransmitters. And if they're chemical, that means we could play with them, right? And we could play with them chemically. So, and just know that neurotransmitters, we play with either the neurotransmitter chemically or the receptor to the neurotransmitter itself. And it produces 4 classes of antidepressants: SSRIs, SNRIs, TCAs, and MAO inhibitors. Okay. Hey, Belle, did you tell your grandma that there's no online for Edison?
No. Oh, no, I did.
Okay, good. Sorry, I'm trying to manage my family as well as you guys are. Okay, so those are the four, and let's look at each of their mechanisms of action. This is a wonderful slide right here, and we already know this, that you have electricity or action potential going down the synaptic bud or the terminal synapse right here in your nerve cell, and then it hits here, and then it releases the chemicals, neurotransmitter, and then the neurotransmitter ends up on these receptors. So if we remember our first chapter that we talked about in this class, I could either enhance these chemicals, make more of them, put more of them in here, or I can enhance this receptor, or I could block them from being released, or I can block this receptor. So you could see, let me make this bigger a little bit. You could see how we play with the chemistry, and SSRIs block the reuptake of serotonin. So what does an SSRI do? So you have serotonin, and typically it would go get, recycled, and there's enzymes and things of that matter to break them down and to bring them back up. Well, what if I block them from going back home? Then there'll be more. Belle, what is your brother doing?
I don't know. I told him to stop.
Tell him to go all the way upstairs because he's starting to tick me off. Okay. Right here, so the serotonin will stay in the synaptic gap longer. And if serotonin stays in longer, serotonin is related to the depression, to antidepressive effects. Because, like I said, who hates sleeping? I love sleeping. Sleep is, I'm a professional sleeper. I love sleeping. We all do. I wish we could be all sleeping right now. It's the best. And that helps mood. So that also states to us that we should also tailor our behaviors. Many of us are burning the candle at both ends. And we're lucky if we get 4 hours of sleep, 3 hours of sleep. Try not to do that. My goal now is I try to get 6 hours, which is really, really rough. There are some days that I'm so busy, and you guys probably have the same thing, that I don't sleep. Like I go 2 days in a row because things have to get done. But what can we do? An SSRI, it blocks the reuptake, and then so it potentiates. If the serotonin doesn't go back up, there's more serotonin here in the synaptic gap, also known as your synaptic cleft. SNRI. Now, SSRIs have nothing to do with norepinephrine. Norepinephrine is another happy neurotransmitter. Now, SNRIs block the reuptake of not only serotonin, but norepinephrine as well. So now it's a double whammy. You not only have serotonin floating around in here longer, you also have norepinephrine floating around in here longer. So that will increase serotonin and norepinephrine levels, and hopefully it'll also alter the mood of your patient. Now, the one thing I also have to stress about, well, we'll talk about dispensing antidepressants. I'm jumping ahead of the game. Now, TCAs are tricyclic antidepressants. They prevent the reuptake of serotonin and or norepinephrine as well. So that's a both A and B question. And what's a tricyclic antidepressant? Well, it will, again, if it blocks the reuptake of both serotonin and norepinephrine, there'll be more serotonin and norepinephrine here in the synaptic gap. Now, another drug that is, remember I mentioned enzymes that break down serotonin and norepinephrine so it can be recycled back up into the nerve. Well, you have what they call a MAO inhibitor, MAOI, known as a monoamine oxidase inhibitor, but we call them MAOs, right? Now, what's next? Oh yeah, here it is. Got lost there for a second. Now, what are some dispensing issues? The thing about messing around with brain chemistry, it takes a while. It could take almost a month for it to work. So it's really hard to keep telling a patient who's depressed hey, just keep on taking it. You'll be better like in 30 days. It's rough. It's a long time. So it's not as needed. It has to be planned. And there are, of course, drug interactions for, chronic dosages of these antidepressants, because they're messing around with your brain chemistry. They're messing around with your neurotransmitters in your nerves. So the one other thing that happens with antidepressants, let's say you are super, super depressed. All you do is sleep in bed, you don't eat. Okay, we're giving you antidepressants, and then it's going to take 2 to 3 weeks, almost a month for it to work. Well, this is one thing that happens in 3 weeks. It might elevate the mood of our depressant patient, and just enough, not to be not depressed, but just enough to be able to go to the gun store and blow their brains out. So around like the 2-week mark, we start monitoring our patient quite closely, because it could elevate their mood enough for a suicide attempt. Suicide attempts, a lot of the times when I was in EMS, and also when I was in medical school under psychiatric service, you notice that a lot of the times when you have patients who do really, really odd behavior is when they take themselves off meds, or they just got a brand new set of meds. So remember, it takes a while. There's a delay of onset, up to 2 to 3 weeks, almost, in some cases, like a month. So you got to be careful when dispensing medication, because they also have side effects. So serotonin syndrome is one of those side effects. It's relatively rare, but it could happen, right? With certain combinations, especially with the combinations with the MAO inhibitors, you've seen that on TV. Do not take with an MAOI. You could get also migraines. And also, again, we have to get to the reason why somebody's depressed. So for example, somebody has cancer and they're depressed about the cancer. They should be focusing on the cancer instead of me adding more drugs to your system, which will cause more side effects. So there's a potentiating effect, and that's a serotonin syndrome. So for example, if you take triptans, you take it with antidepressants, there's a synergistic effect, and you could remember, too much of a good thing becomes a bad thing, and a serotonin syndrome is fatal. Here is some examples of SSRIs, and the really common ones that you really need to know: Lexapro, Prozac, Paxil, and Zoloft, right? Fluoxetine, paroxetine, and sertraline. Prozac, Paxil, and Zoloft. They're prescribed almost like candy now. Like, oh, you don't feel good? Oh, you're having a bad day at work? Here's some paroxetine. And again, I do not recommend just taking these drugs without any psychiatric or psychological psychotherapy support. Taking the drugs, in my professional opinion, is not enough. Also, it's the opinion of my mother, who's a neuropsychiatrist, and she was one for 45 years. And also, she was also a addiction specialist, especially for violent adolescents. That's why the last 10 years of her career, she was a medical director for prisons. So she knows how this stuff sometimes works and sometimes doesn't. And if you don't get to the crux of the matter, again, I've said that like 5 times already, these drugs won't be as much benefit to you. So these ones, Paxil, Zoloft, Prozac, Lexapro, those are the most common. Now, some of these, citalopram, or also known as Celexa, right? We can also use antidepressants for obsessive compulsive disorder. Now, what's obsessive compulsive disorder? Those are the people who can't let go of certain behaviors like hand washing or cleaning, right? To the point where, remember, how do you know it's a pathology? When it starts affecting your activities of daily living. Now, my wife is a clean freak, so she loves cleaning things, but she doesn't have OCD. Now, if she started cleaning instead of going to work, if she started cleaning instead of brushing her teeth and, you know, washing her hair, then that's a problem. And that's how you know you have a true psychiatric disorder, when the behaviors start affecting your daily life, activities of daily living. All of us get depressed every once in a while, but we still all go to work. We still talk to our friends. But if you stop talking to your friends, you stop having social interaction, you stop, and you stop going to work, you stop brushing your teeth, you stop fixing your hair, right, for a significant amount of time, and that there's a lot of that going on. That's already, you're delving into the world of depression. A classic example is, how do you tell bereavement versus depression? So a classic example, my aunt died a couple of years ago, and she died of an aneurysm. It's not my aunt, but she's a very, very close family friend. You guys know how your extended families get just as close as your actual families. Actually, I'm closer to my extended family than I am with my actual family. But my auntie died, and she died suddenly. And her husband, you know, he was going through a rough time, but then he stopped shaving, he stopped brushing his teeth. He even he started going to the bathroom in buckets in the living room, and that's how you know that's the behavior. And then he stopped going to work. That's how you know the behavior is now affecting activities of daily living, or ADL. And we put him on meds, and he got better. Then he bought a truck, and now he's back to work, and he's, you know, he's dealing with it. I can't say that he's happy a year, 2 years out, but he's like the rest of us. He's dealing with it, and at least has some little tiny pleasures. So this is something to look out for, especially now. You know, what do they say on the news? In these hard and trying times. As an adult, when is it ever not? When is it easy and non-trying time? That's what I find funny. You know, it goes, if it's not a AIDS epidemic, it was a crack epidemic. If it's not a crack epidemic, it's racism. If it's not racism, it's political unrest and political divide. You know, it never ends. It never quits. But the way we perceive it and the way we deal with it, that's some, it goes, and to find at least some happiness in this adult life is a challenge. So Prozac, major depressive disorder. This is for people, this is some really, really serious fluoxetine, right? And the thing is, you got anorexia and insomnia, right? And that means your patient doesn't want to eat, and your patient can't sleep. And that will, you know, their mood might be elevated, but that'll irritate the heck out of them. Lexapro, nice to use. Zoloft also, nice, right? Yeah, I've had this. Now, there are some medications like Prozac that, you know, that deal with it, that, you know, have some side effects like insomnia, but there's also others like Zoloft. Their side effect is drowsiness. I've had patients complain to me like, hey doc, this Zoloft is really great. I don't want to kill myself anymore, but I can't stop sleeping. And they complain that I sleep more now that I'm on Zoloft than I was when I was depressed. With any medication, you cannot have any alcohol. And I mentioned this before. The alcohol with certain drugs has something called disulfiram effects. You'll start vomiting uncontrollably. So if your patient is an alcoholic, and of course they're depressed, and you have to get to the source of the alcoholism. And of course, maybe we also prescribe disulfiram so that the person, every time they try to drink alcohol, they'll get sick. SNRI is what they call a second-line drug. We use it when SSRIs don't work, right? So you have your SSRIs, right? But then they don't work. So I put you on Effexor or Cymbalta, okay? And that's an SNRI. And here's the problem. There might be some diabetic neuropathies. So my patient's diabetic, it'll enhance their neuropathy, right? It has some weak inhibition of dopamine, which is good, which is not really that good, but it conflicts with serotonin, norepinephrine. Oh, I probably mentioned in another class. You want to increase your norepinephrine and dopamine. Go to the gym. The American College of Sports Medicine, about 10 years ago, 8 years ago, give or take, they had this wonderful study where they looked at the dopamine and norepinephrine levels of people who work out regularly, and not people like, not like a real hardcore workout, but, just doing something you like dancing or gardening or something for at least 3 times a week for 30 minutes per session. They had increased uptake of, not uptake, they had increased titer or levels of norepinephrine and dopamine. So, oh, by the way, follow up, it's at the same level as it would be if you took antidepressants. And when I don't work out regularly, I get moody. But when I do work out regularly, like I stated earlier, no such thing as a bad workout. And it doesn't necessarily mean you have to join a gym. It doesn't necessarily mean, you have to work out until you vomit and you're cross-eyed. You find something that you love to do physically and then go do it. My daughter Chanel, she loves dancing. She hates going to the gym, but she loves dancing. But my other daughter, Isabella, right? She's waving to you guys if I had my cam on. She runs, right? And she runs, what are you up to, 3 miles? With 2.8? Yeah, somewhere there.
Yeah.
Used to run 5 over the summer when we had time.
4, funny numbers.
All right. And like I said, for those of you who have children, right? Running is boring, but now it's, I don't think she's like really crazy about it, but it's just like brushing your teeth. If you do it regularly, it becomes part of your daily routine, and it fights a whole bunch of things, not only depression, but obesity, heart disease. And unfortunately, my Isabella is a Garais, so she's now marked for diabetes and obesity and heart disease. But how old are you now? 13? 14?
Yes.
13?
13.
Right? Sorry, I got so many damn kids, I don't know how old they are, so I have to ask them on a regular basis. Because, they grow like weeds, and you never know, right? And it becomes regular, and then because it will change her mood so that hopefully she doesn't have to take any anti-hyperlipidemic drugs and cardiac meds or depressive medications. And also, when you work out, I like boxing. Every once in a while, maybe every other week, I hit the bag. When we're all pent up and you got all these issues, hitting the bag and pretending that it's an issue or somebody you don't like. It's very cathartic, and catharsis is that release, that release of energy and the negative energy, and it's really wonderful stuff. Affects her, right? Again, both A and B. Remember, the SSRIs are the only serotonin. Everything else is a both A and B, serotonin and norepinephrine regarding its mechanism of action. Pristique, that's really good. We like it for the negative side effects of postmenopausal women, and also for neuropathic pain for fibromyalgia. You have tricyclic antidepressants, tetracyclic. Just know that what? TCAs, here are some common ones. And the ones that are really popular is Elavil, and what's the other one I like using? I love using Pamelor. The other ones, not so much. Elavil a lot if I use TCAs. Okay. Anti-anxiety, yada, yada, yada. Another thing about some TCAs, might have some cardiotoxic dosages. So be careful when you see that and you know the patient has a cardiac problem. TCAs, they also have cholinergic effects, so blurry vision and drowsiness. And of course, if you see this label for TCAs, there could be phototoxicity, meaning to say is the patient takes TCAs and then goes to the beach, they're going to get some side effects, and it's not good. They're going to get a rash and itching and all this other stuff. MAO inhibitor, again, a second-line drug. You try the SSRIs always first. And you know from the TV commercials, MAO inhibitors, right? I like Nardil, MSAM, right? Selegiline, ooh, I used to use that a lot. They got a ton of side effects, but they're very good at treating the depression. Just know that, read the label, there's a ton of side effects. Here's also another thing that there are dosing schedules. Well, for future training, you're going to need to know when they are, because you can't just get off these drugs. Some other really common drugs that you might hear, trazodone and bupropion. Bupropion, also known as Wellbutrin, we love using that for people who are trying to quit smoking and people who are, you know, at least class 2 obese. They're like serious obesity issues, because you get into depression and you won't be able to follow your, you know, your diet. You won't be able to follow your anti-smoking schedule, right? And we use Wellbutrin as a nice little backup. Now, what's so cool about bupropion is it also blocks the uptake of dopamine. So bupropion is an all of the above. Well, not all of the above. It's dopamine, and just the way the SSRIs and SNRIs work for serotonin and norepinephrine, bupropion works for dopamine. So the three main neurotransmitters that are directly linked to depression are serotonin, norepinephrine, and dopamine. And I told you, norepi and dopamine, they get naturally increased when you work out regularly, and serotonin also gets naturally increased when you have a better sleep cycle. But again, it could be the chicken before the egg issue. Like, you can't sleep because of the depression, or you're sleeping too much, and that's causing you depression. You know, remember, too much of a good thing. But in theory, medically, you're supposed to get 8 hours because when you sleep, that's the only time your brain has a moment to process. That's why not a good idea pulling all-nighters before a major examination. Get good sleep before a major exam. Drug list, bipolar. Now, what's bipolar? We talked about bipolar is there's two extremes, right? You have one cycle, which is mania, and the other cycle is depression. And it's not like within the same day. Like, you can have a maniac or a maniacal episode lasting a week, 10 days, and then a couple of months of depression. And then you come back up. There are many figures in history and famous people in history who had diagnosed and undiagnosed bipolar. One of those people are artists. There was a lovely paper done a couple of years ago. My mother and I went to a seminar based on that paper. And the paper showed if you look at artists, they have phases. There are certain artists that have phases. And the most documented was Picasso. And if you recall your art and history classes from maybe high school or maybe another college, he had his blue period and his red period. So the red period, when he's painting happy and exciting things, and the blue period, he's painting depressing, sad, and awful things. So Picasso went through his stages, and if you look at his life, he definitely had signs and symptoms of bipolar disorder. Another one was Salvador Dali. He's that Spanish artist. And there's one moment he's painting these very psychedelic, very warm featured paintings. And then there's other moments where it looks really depressing. So good stuff to treat bipolar. You'll notice Tegretol and Depakote, right? These two are also epilepsy drugs. Also Depakine, valproic acid. Tegretol, Depakote, and Depakine, they are also anti-seizure medication. So just like in the way that your bipolar patient is extreme, they go from highs to lows in weeks, very, 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 very rapidly and very, very extreme. These drugs, just like what they would do for your epileptic seizures, they calm your brain down. Another drug that's really neat, Escalith, which is lithium, it's really neat, but it's very dangerous. Lithium is an ion, and it's very small, and it goes in and out of the blood-brain barrier. And lithium, the toxic dose is what, 0.3 micrograms or some ridiculous number like that. So it's very easy to overdose on lithium. So we take very good care on our bipolar patient that's on lithium. And remember what I stated earlier in the lecture, maybe week 1, week 2. If you abuse Tegretol, Depakote, or Depakine, guess what you're going to get? You're going to get seizures, right? So if your patient goes off schedule or the dosage isn't optimal for your patient, they could have a side effect of seizures. But we love lithium, but we got a lot of here it is, 0.8 to 1.2 mex or milliequivalent per liter. That's nothing. That's tiny, tiny levels. And that's the therapeutic range. That means anything above that 1.2 mex or milliequivalents per liter, that's already toxic dose. I don't mess with lithium. I send that person straight to the Department of Psychiatry. Let them figure it out. Carbamazepine, Decretol, Divalproex, Depakote, right? They don't like lithium. I like these better, right? But again, got to take it with food, could have dizziness. And these are also anti-epileptic medication as well. Now, let's talk about schizophrenia. Now, schizophrenia is not what laypersons usually refer to schits. People in layperson world, they think schits is multi-personality disorder, which is another topic entirely. What schizophrenia is it's an abnormal processing of thought in your mind. Like, for example, we all right now, while you're listening to this lecture, your mind is probably straying. Let's admit it, right? In between this silly lecture, you're like, oh, what is it going to end? Or, I wonder how cold is it going to be? And I hope I have enough toilet paper for today. You guys know your mind is straying. Heck, you guys know my mind strays all the time. But for a schizophrenic, they can't help it. They get something, they have a train of thought and it won't let go. And it affects their limbic system, which is your this area right here near your corpus callosum in your brain. And that deals with your emotions, right? And it could also lead to psychosis, abnormal condition of your mind. Because just imagine if you cannot control your thoughts. So here's a classic example on how it's called word salad. It's how a schizophrenic, how their mind links one unrelated topic to another unrelated topic, and they can't stop. So it'll be like this. Hey, limbic system pathway goes path train, goes trains. I love trains. Trains smoke. Bic. You know what's in trains? Smoke, fire. What's on fire? Bic lighters. 70s, rock and roll, Aerosmith. That's how their brain, and it won't stop. Just imagine how crazy you would be, how mad your day would be. You won't be able to do anything. And those are the people you see maybe like walking around, walking around the street, and they're like mumbling to themselves because they cannot stop thinking. And that's rough, right? Yeah, on manic episodes, yes, Miss Marissa, they can also have that. Like they're so excited. I had a patient, she had a manic episode, and she had these delusions of grandeur. And delusions of grandeur is when stuff like this, you know what? I'm going to run for Senate. No, not Senate, presidency. No, I'm going to be the ruler of the entire North America. I think I could unite Canada, Mexico, and United States, and I would call it Mexicana or Mexicanada. Maybe I could call it that. And she couldn't stop talking like that. And it was scaring me. And I was a brand new resident, and I'm like, ma'am, please stop. And she can. And then I had to write that down. You know how hard it is to try to get a history from a patient who does that? And but you can see there's a very much difference between schizophrenia, which is a thought, it's a thought disorder, and major depressive disorder, and even bipolar, because major depressive disorder and bipolar are mood disorders. How do you feel, right? Versus schizophrenia and psychosis is how do you think, right? Now, schizophrenic and psychotic, they could break off from reality. So right now, we're all in reality. You're a student, I'm a teacher, we're online. But what kind of hallucinations we have, all right? You could hear voices, you can see things. Remember, we talked about in anatomy and physiology, for those of you who are in my A&P class, you don't really see anything. Who sees things? Your brain. Your brain is processing. Right now, you're not hearing my voice. This is your brain's version of what my voice is. So if I'm annoying and boring, it's not me, it's your brain. Well, at least that's what I keep on telling myself. These people have ambivalence to human life because human life doesn't mean much to them because it's more of the thought process. So like a Charlie Manson, a serial killer, when they get into their psychotic episode, that means they're not in this world. Maybe I told you guys about, I had a patient who thought there were dragons in the emergency room and they were coming out of the ceiling. And then he assaulted a nurse because she took away his magic blanket that was protecting him from the dragons in the ceiling. And she was like, sir, I really need to have that blanket back. And she forced the issue without reading his chart. And what happened? He got pissed and he assaulted her because his life was in danger. Imagine if you really thought the government's listening to you, like what they may, because you know I'm a conspiracy realist, not a conspiracy theorist. You guys know I have so many conspiracy theories based on some data, and I do it to entertain myself. But at the end of the day, do you think it's ruling my thoughts? I hope not. And that's psychosis, abnormal condition of the mind. So be careful with your psychotic patient. They're not with us. They have a very, very different view of the world, and they could see you as a danger. Just imagine if you saw other people as a danger, you'd fight back, and you can get very bizarre or very aggressive behavior. Okay, because if you feel, especially drug addicts could be psychotic because they need the drug. What if I took away water and food to your children? What would you do to me? You'd hurt me. That's why many years ago, elderly patient stabbed me in the neck with a spork. Now, thank God, it didn't really enter like my jugular or anything like that. But the fact that I didn't pay attention to her psychoses, I didn't pay attention. I just thought she was a pill seeker and she pissed me off. And she tried to kill me with a spork. One of the highlights of my medical career, actually. So antipsychotic, right? That will help block these psychotic thoughts and the hallucinations and the delusions, right? And what are some real common first gen, and you've heard of them, Haldol, Compazine, right? Those are my two favorite ones. But all these other ones, they're just as used a lot. But I love haloperidol and Compazine. We use that to we use Compazine along with like a sedative. So when they're having a psychotic episode, we push that into their butt intramuscularly. In the upper outer region of your gluteus maximus, which is the definition of the term that I just used, your butt. And again, we will look at that and learn that in our laboratory regarding the method of, method of getting the drug inside your patient. Side effects, antipsychotics, there's a whole bunch. It's one of those things, all of the above. But this is really bad. When they get dystonia and akathisia, they start having these movement disorders. And sometimes it looks like Parkinsonism, where, they're shaking their hands and stuff like that. And you could see all of the above, because an antipsychotic medication has to be severe, because you're trying to tone down psychotic mood and the psychotic thought, or what they call psychotic ideation. So that they don't want to blow up the world, or they don't want to hurt everyone around you. And we use other drugs to, you don't have to memorize this, but we use other drugs to alleviate a lot of these side effects. That's why your antipsychotic would most likely be combined with some of these. I like meclizine, which is Antivert, and Benadryl, because they have like GI disorders. So meclizine, we use it like as an antiemetic, anti-GI stuff. And diphenhydramine, Benadryl, this is low-dose Benadryl is really good, for sleeping and for as a calming agent, even though Benadryl is typically used as anti-allergy. Your atypical antipsychotics. We mentioned earlier that you could have weight loss. Well, you could also have weight gain and hyperglycemia. Here are the ones and the most popular ones is Zyprexa, Seroquel, Risperdal, and Geodone. And if you notice, all the atypical antipsychotics, and most of them end in pene, clozapine, olanzapine, risperidone, and all pene and one. But Risperdal, Geodone, Zyprexa, yeah, I forgot. Almost all of them are really popular. Abilify and Clozaril. But you can see here, man, these are things that most Americans don't need: weight gain and hyperglycemia. But if you're having some serious if you're having some serious psychoses, these are lovely things. But man, there's a lot of doctors who also use this stuff for antidepressants. Again, I like referring back my patient to psychology and psychiatry, and to get to the root of the problem, instead of just delving out meds real bad. Ooh, Clozapil. It'll drop your white count. So this is no bueno for anybody who is a higher risk for infection. Abilify is nice. You can also use it for bipolar. Dispensing, olanzapine, Zyprexa. Again, dopamine, serotonin is nice. Very popular, Zyprexa. Seroquel, very popular, and has lesser blood problems like its neighbors. Risperdal. Now, first drug approved for autism. As a parent of 2 autistic children, let me tell you, don't give them, you got to look at the behavior, and you got to look at the source of the behavior. You can't just give somebody Risperdal or give somebody Adderall just because they look like they have ADHD. Because autism is a spectrum. You have some kids where they'll just appear odd and you'll barely notice it, right? And then you could be like my nephew CJ, where it's super obvious that we have to use it, things like Risperdal, to calm him down. Because my nephew CJ, he is non-communicative. He's a good, 5'10", 230 pounds. So he throws a fit like a 5-year-old. You don't want to be around. He starts having some psychotic ideation because he loves Doritos as much as I do. They had to actually put a lock and chain on the cabinets because he used to rip out the cabinets with the little locks. So that's when you give Risperdal. That's when you get Risperdal, when the behavior dictates it. But don't think that, oh, you're autistic, you should get a Risperdal. That's called reflex or knee-jerk medicine. And that's not why we all go to school. You got to look at the signs and symptoms. And remember, you got to look at the subjective, which is the history, and you got to look at the objective, which is the physical examination and actually looking at your patient. So my nephew CJ would be somebody who would get Risperdal, but my son Nelson Hermie, hey Belle, how old is Nelson Hermie now? What, 16? 16, he throws a fit, right? Because remember, autistic children, they have a misrepresentation of sensory. They process sensory very different. So if he sees something, especially, here's the thing about things that are falling out of the sky or falling down or crashing, he gets really, really upset if he sees something like that. But what do? We control the behavior by when we see a scene that we see his anxiety coming, he already knows what to do. He starts saying, and then what does he do? Turn off the TV. And if he doesn't turn off the TV, we turn it off for him. And then we lead him into a nice quiet place so he can process it. And that's my little side bit regarding autism. There's no drug for autism. Autism is part learning disorder, part developmental disorder, and a lot is unknown regarding autism. I've read every book on it because I not only have one, but I have two sons who have it. Anxiety. We all have anxiety, but again, when the anxiety, right, gets to the level that you cannot perform your activities daily living, like for example, I have a nephew. He hasn't been outside since March of 2020, because now his anxiety is so bad that he has agoraphobia. He refuses to leave the house, and that's scary. He is, like, we all have a state of uneasiness, even me as a medical professional. When I go outside, my thing is like a couple of weeks ago, I don't know if I shared with you guys, I almost got in a fight with a dude at Five Below because he was telling me I was wearing my mask wrong. And I'm like, excuse me? Right? And you know me, I goes, I'm a medical professional, I can hold my temper, but as a human being, not so much. Right? So, but you know, I just left the scene, but it got a little scary. And that's why now, that's my anxiety. Usually when I go out, like, who's going to mess with me today? Because I have on my personal level, I have a temper and I don't like it. And it causes me some anxiety. But does it mean that I need a sedative? Well, if you talk to my mother, she says I need a whole bunch of antipsychotics. But I'm teaching, right? But if the anxiety is so bad, you're going to need a sedative. And I mentioned a really popular one is benzodiazepines, and bupropion.
Mom has a little pain in her thing, your stomach-like area.
Okay, gang. It's at this point, I wish I could continue with this medication. I have a little bit of a medical emergency, so I will continue this lecture and post a video later. So let me take attendance real quick. I have 1, 2, 3, 4, 5 students, and I all wrote you down. So everybody, sorry, I have a little bit of medical issue I got to go.
That's okay, sir. You just go take care of that, and you have a nice day.
All right, have a good one, everybody.
All right, bye-bye.